KMCRIC 웨비나를 시작하도록 하겠습니다. 편의상 제가 잘 못하지만 영어로 하겠습니다. 오늘 연장은 외국분이시라서. Good evening, everyone. I'm Hyang-suk Lee at Korean Medicine Convergence Research Information Center at Kyunghee University, and I'm pleased to have Professor Julie Bruce at Warwick University, UK, for our this year's first webinar. And actually, Professor Kon-young Kim at Busan National University kindly recommended her for our seminar, for our webinar. So I'd like to ask Kon-young to host this webinar. Would it be okay?
Yeah.
Thank you.
Yeah, thank you. So thank you everyone for coming today. So we have a very special guest speaker, Professor Julie Bruce. She's, as you see, the Professor of Clinical Trial in Warwick Clinical Trials Unit in Medical School, University of Warwick, UK. So she has contributed as lead or co-applicant over 60 grant submissions since joining Warwick CTU. And she has published over 130 papers on peer-reviewed journals, including high-impact ones such as BMJ or New England Journal of Medicine and JAMA publications. And her current role in Warwick CTU is oversight of multi-center clinical trials within the surgery, pain, and rehabilitation theme, as well as supporting and mentoring junior academics and clinicians for their research career development. She'll introduce one of UK multi-center trials conducted by her team for patient after breast cancer surgery and the problem of chronic post-surgical pain. So please leave your comments or questions on the chat box or directly ask her in Q&A time. 질문은 채팅창에 남겨주시거나 아니면 끝나고 Q&A 타임 한 20분 가질 겁니다. So, okay, so I'll hand over now to Professor Bruce. Please, Julie.
Thank you. Can I, and to Dr. Suk as well, can I check you can hear me all right?
Clear.
Yeah, perfect,
yes, it's
perfect. Okay, and I will try, I'm not very good on Zoom, but I will try, and hopefully this works okay, but if there are any problems, please just speak up. And what I'm going to do, I'm not able to see hands, so please just stop me and shout out if there's anything that you want me to explain further or anything that's not clear. But I do plan on talking for about 30 to 40 minutes, and then we can have some discussion, probably about 40 minutes, and we'll have some discussion at the end. So let me just see if I can move on. So I'm going to talk about the prevention. So one of the clinical trials that we had conducted at the University of Warwick, and it's called the UK Prevention of Shoulder Problems trial. So I'm presenting this on behalf of our team. As Kun-young said, there's a lot of people were involved in, this is not going to move forward. Okay. I might have to look over there because my slides are not moving forward as I hoped. Okay, so first of all, thank you very much for the invitation. And I have been trying to practice on Korean, so 안녕하세요 to everybody. So I'm going to start by just giving a little bit of an introduction about the University of Warwick, and then I'm going to talk a little bit about some of the common complications that can happen after breast cancer surgery and breast cancer treatment. And then I'll go on and tell you about the clinical trial where we tested what we call a complex intervention. So this means it's not we didn't test a drug, we were testing an exercise program with a behavioral component. So these are often termed complex interventions because they have multiple components to them. So first of all, just showing you a picture of the University of Warwick from almost 60 years ago. So in UK terms, it's a relatively new university. So it's coming up to 60 years old, and it was established back in the 1960s, and it had its very first intake of students in 1965, and there were only 450 students admitted at that time. However, since that time, it has grown enormously. We now have just under 30,000 students and over 7,000 staff, and it does bring in a lot of research income. And in terms of research quality and teaching quality as well, it's often ranked either number 8, number 9, or number 10 in the UK, depending on which indices you look at. So it does rank very well for a fairly new university, particularly in comparison to the older institutions such as Oxford and Cambridge. So where is it located? So we are north of London and we are east of the city of Birmingham. And the university is located halfway between the town of Warwick, which is quite a small town, and this is just a picture of the famous Warwick Castle, and halfway between Warwick and the city of Coventry. And this is a picture of Coventry Cathedral, which was bombed in a Second World War, and there's a new cathedral built alongside it. So that too is also an iconic image of Coventry. So I'm based in the Warwick Clinical Trials Unit, which is one of the divisions in the medical school at the university. And it was created back in 2005. And we also have, so we have our own division, but we also have a small research centre in the local Coventry Hospital. And it has also grown, so it started off with a very low number of staff, with less than 10, and we now have a multidisciplinary unit of over 100 staff, with statisticians, health economists, clinical trialists, etc. So, and this is the trials unit in the top picture here. And we also very much welcome visiting academics, and we had the pleasure of welcoming Dr. Kunyung Kim and his family as well. And Kunyung joined us between March and left to come back to Seoul in February last year. So our research themes in the clinical trials unit are, we have 4 main themes. So we do cancer trials, emergency care trials, some maternal health trials, and one of the biggest portfolios is the surgery, pain and rehabilitation theme. So we have a large group of researchers interested in this trials of this particular topic. And these are just some of the logos. I'm giving you some, if you're interested in any, you can go to the website and look, but we've done trials on falls, fractures, opioid reduction, ankle rehabilitation, chronic headache rehabilitation, long COVID, and robotic hip surgery as well. So you can see, and this is just a selection of the trial logos, so you can see there's quite a spread of work that's undertaken at the unit. And a lot of these are complex intervention trials as well. Okay, so now that's given you a little bit of background about Warwick, about the trials unit. So now I'm going to give you an example of one randomized control trial that was completed and published a couple of years ago, but I'm going to use this as an example of how we developed and how we delivered a clinical trial, and I'll share some of the results with you as well. So we were interested in looking at how we could help women who have complications after breast cancer surgery. And we know that chronic pain is common. It can affect up to 30% of women. Also, lymphedema is a common problem and can affect about, on average, 20% of women after their treatment. And the image down below gives you an example of severe lymphedema, and you can imagine how disabling that is. It can affect daily activities, it can affect ability to drive, and ability to do sport, etc. So other complications can include infection and also a condition called cording in the armpit after axillary node surgery, And this can lead to upper limb problems, leading to things such as difficulties flexing the shoulder, abducting the shoulder, and also externally rotating the shoulder. So we now know quite a lot about these complications. However, this wasn't always the case. And if you go back in time and look at the literature from the 70s and 80s, there was very little known. And surgical textbooks reported this was a rare condition. So, for example, chronic pain after breast surgery was considered to be rare and also a mild side effect. And there were single case studies, for example, talking about nerve entrapment syndrome. So really the burden of these complications was very much underreported at that time. However, from about the 1980s, 1990s onwards, more and more studies were being done asking women about how they were after their cancer treatment. And one important study was this Danish survey. And this was important because it was the very first large-scale national study. And this was a group of researchers led by Henrik Kellett, who is a surgeon, and they aimed to look at the prevalence of pain and the risk factors of pain in women undergoing breast cancer treatment. And the design was very good. It was cross-sectional, but because all women undergoing treatment were on a national registry, they had a national sample. And it was a straightforward design where they sent out a questionnaire and they asked women about the location of the pain and how frequent their symptoms were. And they recorded this on a 0 to 10 numerical rating scale. So what did they find? So they followed women up for, or they surveyed them at 2 years post-operatively on average, and they had a very good response rate. A response rate of almost 90% is very good for a questionnaire survey of the population. And they found that almost half of women still had pain in more than one area, and over almost 60% had sensory disturbances at the area of their surgery. And this was 2 years post-operatively. And they were able to look to explore some of the risk factors and shed some light on the risk factors, finding that younger women were at increased risk, and also those having a clearance of the axillary area were at greater risk, and then also women having radiotherapy to the axilla as well. Is everybody okay? I just heard somebody. Did somebody ask me anything?
Oh, no, it's okay. Just noise.
Carry on. Yeah. Okay.
Yeah, carry on, please.
So this was published. So this is a cross-sectional design, which is a straightforward design, but this was published in a major medical journal. So it really did help highlight the problem. So could exercise help prevent or treat some of these problems? And at the time we were thinking about doing the trial or developing the trial, we looked at the literature, and there had been a systematic review, which is quite old now. And at that time, there had been 24 clinical trials testing exercise for women having breast cancer treatment. There had only ever been one trial done in the UK, and it was small, it only had 61 patients. And there were other problems that the review authors identified. They identified that the sample sizes were small, the trials were very poor quality, they were very mixed. And also, when you were given exercise, there was no information, or there was a lack of detail about the information on the exercises prescribed. So there was a lack of information about the content, about the duration, and about the delivery. And also, few of these studies looked at function or disability. A lot of them looked at shoulder range of movement only. And also, there was still some concern about whether, if you prescribe exercise after a procedure and women start doing exercise too quickly whether you might even increase the risk of infection or lymphedema. So there were still some unanswered questions here. So given this clinical uncertainty, there was a need for a high quality trial testing exercise for the prevention of shoulder problems. And this was advertised by the UK funder, the National Institute for Health Research. And our unit were successful with seeking being awarded funding. And so we set out to answer this research question: what is the clinical and cost effectiveness of an early supervised exercise program compared to usual care delivered to women who are at higher risk of developing shoulder problems after breast cancer treatment? So we were not going to focus on everybody, but we were only going to invite women who were particularly higher risk coming into the trial. And we were interested in the outcomes of upper limb function, pain, health-related quality of life, and other adverse events as well. So who did we want to include in the trial? We wanted to include women at least 18 years old, and we didn't set an upper limit. So women could be in their 90s, 80s or 90s. We did not set any upper age limit. We wanted to be as inclusive as possible. We only included them if they were having their first breast cancer operation. So if they'd had previous surgeries or previous cancers, they were excluded from the trial. And then, as I said, if they were at risk of shoulder problems. So how did we determine at risk? So this was based on other literature. So we knew from the Danish cohort or cross-sectional study and from other studies that women having an axillary clearance, where all the nodes in the axilla are removed, they were at greater risk. Anyone having radiotherapy to the axilla or the supraclavicular shoulder area, and also women who had shoulder problems. So if they already had poor mobility and poor function related to shoulder conditions, they would be more likely to have postoperative problems. And also there was some literature suggesting that women with a higher body mass index as well. So these were our high-risk eligibility criteria. We excluded men, even though men do get breast cancer, but a much smaller proportion. But for the ease of the experiment, we excluded males, and we also excluded women having immediate breast reconstruction bilateral, or if there was any suspicion of metastatic disease at the point of recruitment. So this is the trial design. So it's fairly straightforward, two-arm, a parallel randomized controlled trial, parallel arm. And we did our sample size calculation based on the primary outcome, which was the disability of the arm, hand and shoulder function scale, or it's a disability scale. And so our sample size calculation was for 350 women, of which 175 would be randomized to each arm. And we aimed to follow women up for 6 weeks, 6 months, and then 12 months. And this was because the previous trials in the systematic review were very short and none of them had done a long-term follow-up. So we wanted to see how women were 1 year after their treatment. And we aim to recruit from about 10 breast cancer units in England. And here are the outcome measures. So the disability, the DASH scale, as I mentioned, but also pain intensity. And we also looked at neuropathic pain as well, using the DN4 scale. And also healthcare resource use, because we wanted to look at health economic outcomes as well. Okay, so I'm now going to talk about the trial interventions. So we wanted to compare usual care in the NHS versus a new exercise programme. So we really started where we didn't really know what usual care was in the NHS, and we didn't have a defined exercise programme to test. So we had to do work around both of these elements before we could start the trial. So in terms of finding out about usual care in the NHS, women are usually in, they have an operation and they go home on the same day. So they could have a mastectomy, they could have their axillary clearance surgery, and generally they're discharged within 23 hours. And usual care was to be given a leaflet from the hospital telling them to do exercises after their operation. So we contacted a sample of hospitals, we reviewed the leaflets, and we found that they were very variable in what they recommended women to do. So there was variation there. And we did find that some of these, not all, but some were fairly poor quality. So they were photocopied, just a page of exercises to do. And this is one example from a department, which is a black and white handout, and it doesn't even have an image of a female. It's got a picture of a man doing exercises, which is not really appropriate, we felt. So we did a bit more digging and we found some very nice leaflets produced by one of the breast cancer charities. They were colourful, they were quite informative, so we decided to use these leaflets for the usual care comparison. And then we set about doing some work to develop an exercise programme as the comparison. And what we aimed to do was develop a programme that was led by physiotherapists, but that could be done at home and could be progressed over time as well. So there are some guidances. So we followed the MRC guidance for the development of a complex intervention. We sort of engaged with cancer patients. We did some qualitative interviews with cancer patients, rehabilitation experts, and we ended up coming up with a long list of potential exercises for inclusion. Then we had a consensus meeting, and then we narrowed down our exercises. So the final programme had 3 core components. So we had shoulder exercises for our stretching and strengthening. We also had some behavioural components where the physiotherapists would talk to women and find out about the barriers to exercise and try and address these barriers. And this was to try and encourage adherence to the programme. And then also there was a physical activity component. So we recommended 3 face-to-face appointments, and these were recommended the first week, the first month after their operation, and at 3 months as well. So women could have 3 appointments with a physio, but they could also contact the team for telephone support if they felt they needed more support. And they were allowed additional appointments if they had any problems or were struggling. They were allowed more than 3, but 3 was a minimum we recommended. And we spent some time doing photographs of the types of movements, and we developed very clear instruction manuals. So there were forward, side and open chest movements, and a menu of exercises that women could select. And this is just an example of some of their materials that they were given. And this is an example of the physical activity programme. So it was very light activity recommended in the first month, and then gradually progressed to more sort of moderate and extreme, moderate intensity activity. And women who were randomised to the exercise programme were asked to complete planners and diaries, and these were returned to the team so that we could see how they were progressing over time as well. Okay, so as with any clinical trial, we should register the trial. So the trial was registered on the national registry, or the international registry, I should say, and the protocol was published in the BMJ Open. And we also published the paper describing the development of the exercise intervention. So all of the processes we followed were fully described in a publication, just so that others could replicate that if needed. So our recruitment went very well. We aimed to recruit 350 women, and we ended up over-recruiting. We just recruited 392 in total, just under 400. And we recruited from across England, from 17 different cancer centres, and we trained 44 physiotherapists. So there were a lot of staff involved with delivering this trial. And it's good to see that we were able to recruit from north of England, right down from London, and right down from the southwest as well. So we had a very good spread of rural and urban centres. This is the consort diagram. So we had 191 allocated to each arm. We ended up screening just under 1,000 women. And some women declined to participate, and also some women were unable to be approached or did not meet the inclusion criteria. And we also had some withdrawals as well. So there was a slightly higher withdrawal rate in the exercise arm. So 20 women withdrew from the exercise arm and 15 women withdrew from the usual care arm. So we had lower numbers for our primary outcome at 12 months. But regardless, this was still the largest trial that had ever been conducted. So in terms of results, so the mean age of women coming in was 58 years, and a high proportion had an axillary node clearance, and the remainder 20% had other criteria that would have put them into the high risk category. In terms of uptake and adherence, we had very good adherence to the exercise program. So it was 94% of women came along to one face-to-face session with the physiotherapist, and 80% attended 3 or more sessions with the physiotherapist. So we're very pleased with this, because often with some of our other complex intervention exercise programs, adherence is around about 50 to 60%. So this was higher than we expected, actually. So in terms of the results, so these are the key results, so the primary outcome. So this graph is showing you the mean and 95% confidence interval for the scores of the DASH, so the disability of the arm, shoulder, hand scale. And you can see at baseline, the groups are very similar. And by 6 months, they're beginning to separate. And by 12 months, there's a clear difference. So where there's a higher score indicates more disability. So women in the usual care arm actually got worse over time. They had more disability, and those randomized to exercise improved, so their disability reduced over 12 months. And we did 2 analyses. So we did the ITT analysis, planned analysis, and then also there was a case analysis only looking at the effect in the women who attended 3 or more sessions, so the 80% adherers, and there's a greater benefit if they attended all sessions. This graph shows you the pain outcomes. So we asked women to describe their pain intensity in the area they had surgery. And we found that the exercise group by 12 months were half as likely to report moderate to severe pain. And first at 6 weeks, there was a difference at 6 weeks and a difference at 12 months, but not at 6 months. But again, there was a halving by 12 months. And then also this is the neuropathic, the DN4 data. So you can see women that only less than 10% had neuropathic symptoms at the time they were recruited. Now, 10% is slightly higher than the average in the general population, but these women may have had some kind of biopsy taken before their operation, which may have contributed to some symptoms at baseline. There was an increase in neuropathic pain in the exercise group at 6 weeks, but this had over time, as they continued doing their exercise, there was a benefit. So where are we at? 15%. So it was 15% of women had neuropathic pain symptoms at 12 months compared to 25 or 28% in the usual care arm. And then finally, the other outcomes. So looking at the other outcomes, they had better, those doing the exercise program had better physical quality of life at 6 and 12 months. We didn't find any difference in the emotional health, so in the emotional health related quality of life scale in the SF12. And reassuringly, if you remember, I spoke about there were concerns about the increased risk of infection and the increased risk of lymphedema. There were no differences. We found no differences in the rates of infection or in the rates of self-reported lymphedema at 12 months. So this was going by arm heaviness and arm swelling. So that was reassuring. We knew that recommending exercises and from the 7th postoperative day was safe for women. And then looking at the cost, so the health economic team undertook the cost effectiveness analysis, and overall the programme cost of £129 per patient. But when we looked at hospital admissions, we looked at hospital stays, outpatient attendances, etc. And overall, the women in the exercise arm had lower number of hospital contacts. So this resulted in a cost-effective, the exercise being cost-effective when it was compared to usual care. So this was a very good finding. So really just to summarise this particular trial. So this trial was the first large-scale trial in women at high risk of developing complications. We had good uptake to the trial overall, and we had good adherence. We had high attendance. We were pleased with the intervention fidelity. We did find that those allocated to exercise had improved arm, shoulder and hand function over 12 months, and also better physical quality of life and reduced pain. So there were a lower risk of moderate to severe pain. And also importantly, we recommend that this programme is cost effective, and we can recommend implementation in the UK NHS. So these are what I've not covered today are some of the qualitative findings. So we also did qualitative interviews. So there was a process evaluation done as part of the trial. So we did qualitative interviews with patients in the intervention arm, with the control arm, and also with the physiotherapist delivering the trial. And there was a very nice paper by Sophie Rees, our qualitative researcher, published in the BMJ Open. I've mentioned the trial protocol and the methods they were published, and the main trial results are published in the BMJ. And there's also quite a detailed funders report as well. And then because the intervention was found to be cost effective, some of the team then spent some time after the trial was finished developing the intervention ready for implementation. So it's been developed as an online training course so that physiotherapists and healthcare staff can register with this company called FutureLearn, and they can register to do this free online course to learn about the components of the programme. And I've got there over 900 have enrolled, but we know that there were over 1,000 have enrolled. I just haven't updated this slide. And however, there has been a bit of a change with the company FutureLearn, so it's been taken offline at the moment and is going to be being transferred to another platform. But you can certainly go to the website and see this online training course if you're interested in learning more about it, or I can send you details. Okay, so I just want to highlight, I haven't even got half of the staff down here, but we have a large team. We've got grant holders, we've got a large team of the Warwick CTU staff, we've also got the clinical teams, surgeons and nurses, the physio team. So it does take a lot of people to deliver a multi-centre, pragmatic randomised control trial. But I will stop there. And then we can have a discussion, and I'll be very willing to take any questions. Thank you.
Thank you very much for the fantastic talk. So the audiences will have an opportunity to directly ask questions to Professor Bruce. 혹시 지금 질문 있으시면은 해주시면은 영어로 직접 해주셔도 좋고 한글로 해주셔도 좋습니다.
제가 질문을
먼저
해야 될 것 같아요. Thank you, Professor Bruce. It was very nice presentation. I enjoyed it very much. The most impressive thing was your clinical trials unit's aim is to transform lives of patients. That was very impressive. Yeah. And I, regarding the exercise program intervention, the patients actually see physiotherapists.
Yes.
Right?
Yeah.
So the amount of attention given to patients would be quite different from that of control group. Have you considered that? So
yes.
I mean, the intervention's effect would not just exercise program, but the attention.
The therapeutic effect.
Yeah. Right.
Yes. Yeah, you're absolutely right. It's just that one of the reasons we did this, because women don't see a physiotherapist routinely. They are given a hospital leaflet and they're sent home. So they don't have any physiotherapy because the physiotherapy services are busy. They don't have enough staff. But they were finding that women were presenting to physiotherapy 12 months, a year, 2 years down the line because they had problems. And so it was it was testing whether you could prevent some of these problems further down the line. So you're right, the usual care arm got a leaflet. The intervention arm had 3 appointments with the physio from 1 week, 1 month, and 3 months. So we don't know, but yes, so the physio spent the very first appointment doing an assessment. So they were able to assess their movement, assess their wound, they would prescribe which of the exercises they wanted them to do. They then asked them to come back at 1 month to see how they were coping, to progress them into doing strength exercises, and they were given a TheraBand to do these more advanced exercises. And then they were just kind of told to come back in 3 months. So they were sent home. So the women were very much working on their own at home and following the program themselves. But yes, you're right, there is a therapeutic alliance there between the therapist that the control arm women didn't have. But it's very difficult to unpick what is the active component. Is it the actual TheraBand activity, or is it the process of talking to the patients?
Right. Thank you. And you said you recruited 10 breast cancer units for your trial.
17. We aimed to start, we thought at the start, you always tried to think how many centres you're going to need. So you calculate your sample size, you think about how many centres you can recruit from. So we originally thought it would be 10 centres, but then when we started, recruitment was quite low at some centres. So you always have very good recruiting centres, but also poor recruiting centres. And we didn't want the trial to run too long, so we increased, so we ended up having 17 in total.
17, right.
Yeah.
Could you please share any strategies or tips?
Sorry, could you repeat that?
Yeah. Could you please share any good strategy or tips for, to involve, trial centers? It's always a difficult part.
It is. I think we did have poor recruiting centres, and we would telephone them and ask, because sometimes they were in different parts of the country, but we would travel, so we would ask 2 or 3, so either myself, the trial manager, or another member of the team, to go and visit the team, and we would make a face-to-face appointment, speak to the surgeon and speak to the breast care nurses, and remind them of the importance of the topic, and almost just go bring chocolates, really try and engage with them. And then also we use Twitter quite a lot. So every time they recruited a patient, we would advertise on Twitter, tell them they were a high recruiting centre, etc. Also sending newsletters to engage them, and sometimes giving who the top recruiting centre is or the top team that month. And we would take photographs of the team as well and put them in the newsletter, and send them chocolates and things. It is hard. It is hard.
Yeah. Okay. We have 2 questions in the chat box. So, 임병태 교수님 혹시 직접 하실래요? 아니면 Okay. So, there's a question from Professor Jung-tae Lim. So, he's saying he's curious about the qualitative research you've done together. So, if you found anything unexpected or interesting in your qualitative research, can you briefly introduce some points?
Yeah. I'm trying to remember. We did find we found some interesting results with the physiotherapists, because the physiotherapists were not used to dealing with these patients. The physios were used to dealing with people with musculoskeletal injuries. So it was MSK injuries they generally treated. So this was a new population for them, dealing with women with cancer and side effects of cancer. And some of the patients were younger women, so they could be in their 30s or 40s, and they were of a similar age to the physiotherapists. And some of the physiotherapists felt this was emotionally difficult for them because they could identify with some of the cancer patients. So we underestimated the impact on the emotional health of the physiotherapists, and they enjoyed being able to meet with other physios and talk about this and almost debrief, if you like, and they wanted to debrief with the team as well. So that we had a physiotherapist researcher who was responsible for going around checking they were following the manual, but also she was there as kind of a support to them as well. The other thing the physiotherapist said was, because they were used to working in an outpatient clinic with people with bad ankles or osteoarthritis, they would just lie them on a bed and pull a screen around them. But with these women, they couldn't do that. They needed a private room with a door so they could talk to them and allow the women to cry. So they needed privacy, and they needed a bit more emotional support as well. And one more thing I remember from the patient interviews, the ladies who were interviewed in the intervention arm doing the exercise program, they liked it because they felt, some of them talked about having a sense of control, so that they had control over their own recovery. They had something to do they could adhere to, rather than the rest of their cancer treatment, they were being told what to do. So it was the surgeons telling them So they had no control, they just had to receive the treatment, but with their therapy, they felt they had self-control over that.
Thank you, Julie. And the second question in the chat box is from the Professor Sang-eun Lee in Dankook University. So in the trial, is there any markers and further analysis for good responders in exercise? So
that's a really good question.
Yeah,
we have planned to do more work for that, to do a responder analysis, but we haven't had the time to do it. But that is something that was on our radar. We have worked with a scientist we've just had a publication out last year, which I forgot about. I probably should have mentioned it. And this is with a scientist, Dr. Conrad Harrison at the University of Oxford. And he's very interested in outcome scales. So he's very interested in the DASH scale. And so he took the trial data set and found that the DASH scale can be, so traditionally it's analysed as one single scale, but he has done some psychometric analysis to show that actually it can be split into two scales. So I can certainly give you the reference for that. So that's a little bit more analysis around the patient-reported outcome measure. So it sort of shows it's got two domains rather than, so you could analyse it as two domains rather than a single score.
Thank you, Julie. And there's one more questions from 배창환 선생님. So his question is, how much intensity of exercises were safe and most effective? So maybe
another great question. Okay, so for the exercises, we were cautious to start with on this. So when they saw the physiotherapist on the 7th to 10th postoperative day, we did not recommend any strength exercises. It was purely stretching. And so women were told not to raise their shoulder above 90 degrees for the first 7 days. But after 7 days, they could start moving their shoulder or their arm higher. But the strengthening exercises were only introduced after 4 weeks because we were concerned about wound breakdown and potentially increasing infection. And also some ladies still had drains in their wounds as well. So the intensity was ramped up from 1 month onwards. So we can think of it as a program. So we can say that the program is safe. It's very difficult to unpick. So it kind of comes back to Dr. Sook's question. So what is the component that is driving the effect? Is it the therapeutic alliance, or is it the strengthening exercises, or is it the stretching exercises? I think we cannot tell that because we've analysed it as a program as a whole. So yeah, I wish I knew.
Thank you. So any other questions from the audiences?
Just just to sort of say that is an issue with these complex interventions where you have multiple components. So where you have a physical and a behavioural component or psychological input as well. And we analyse it. So it's almost like a black box intervention.
Yes, right. So, okay. So can I ask a question, Julie?
Mm-hmm.
Yeah. So yeah, we are most of the audiences, including myself, Korean medicine, the doctors and practice acupuncture or other kind of like complex interventions in our routine life, and also do research in a framework of complex intervention. So So in your experience, what's the most important aspect when designing trials for complex intervention and the effectiveness and safety research in so can you give some advice?
Okay, that's a difficult one. I think being very clear about the intervention and setting out your intervention in a framework so you can see the key components. So you need to know exactly what the minimum that you want the participants to have. So it's really thinking about what is the minimum dose you want to give that you would expect to have a therapeutic effect. So that kind of relates to the case analysis where we assumed if they had 3 or more face-to-face appointments with the physio, they were high adherers because they attended their appointments, and the assumption there is that they were doing their exercises. And then you can see more of a dose response. So for some of the other complex interventions at the unit, so there is a trial on long COVID. So we're doing a complex intervention with long COVID patients in the Regain trial, which is just about to come out in the BMJ. And there it was recommended that, and it was an online intervention, and there were 8 sessions recommended, 8 group psychological support sessions, and there were about 6 exercise classes, group exercise classes. So we had to decide amongst the team, think very carefully, of these sessions, how many do we think is enough to receive the dose of exercise and the dose of psychological support. So we recommended at least 5 out of the 8 and at least 6 out of the 8 exercises. So we felt that if patients had engaged enough, we would be convinced that they'd covered enough of the material, that they had received the dose of the complex intervention. So I think really thinking carefully about your intervention design, breaking it down and having a framework, and using, for example, the MRC guidance for developing something and making sure it's clearly described. And this is where a lot of the trials had fallen down before, that we didn't know what was given. They said we gave shoulder or arm, upper arm exercises, but they didn't describe what movements, what direction, when they were started, how long for, how many times a week, etc., just so that others can see what you've given.
Thank you very much. Okay, so we have one more questions in the chat box. Yeah. 이예슬 교수님 혹시 직접 해주실래요? 계신가?
So a minimum rest period adopted, yes, so 7 days. So it was gentle movements for the first 7 days, but even after 7 to 10 days, they could start the stretching. So it was definitely, so there were 3 different movements. Well, we told women, we described them as side, forward, and open chest. So we made it lay-friendly movements. So they could start the side, open chest, and forward exercises from the 7th to 8th post-operative day, but only after they've been assessed by the physiotherapist.
Oh,
we did have one adverse event where a drain fell out.
Thank you. I was just wondering, so did you recruit the patients prior to the axillary node surgery? So you recruited them before and you asked them to rest for 1 week and then start exercise?
No, so we did recruit everybody before their operation. So, and there are difficulties with that because some women go into theatre thinking they're not going to have an axillary nude clearance, and they end up having an axillary nude clearance. So we did allow, so I didn't mention that in the talk, we did allow for women who were deemed to be low risk preoperatively, we did allow a small proportion who'd had an axillary nude clearance, and we recruited them immediately post-operatively because they were high risk, their risk status had changed. But anyway, and back to your question, Lisa, yes, so we got them to fill out the questionnaires before their operation. They had their ANC, and then they could only do gentle arm movements in the first 7 days, and then they started the program after 1 week. So they followed the breast cancer care leaflet for the first week, and then they started the program.
Okay, apologies for not showing my face. I'm in the car right now, and the background is super dark. I just didn't want to scare everyone.
That's okay.
Just another quick question. Did you do a subgroup analysis by the types of chemotherapies? For instance, you also searched on neuropathic pain, which could definitely be altered by the differences in the types of chemotherapy that the patients received?
We recorded all of the clinical variables. So we recorded we adjusted the analysis. So we adjusted by type of breast surgery. So whether it was mastectomy or lumpectomy. We also adjusted by radiotherapy, whether they had it was crude analyses of whether they had radiotherapy or no radiotherapy, and then by whether they had chemotherapy or no chemotherapy. We didn't actually break down further because we didn't have enough of a sample size to do specific drug classifications. So, but it was all adjusted by chemo versus radio, etc.
Okay, thank you very much, Julie. So we have 2 minutes left. We're running out of time. So one last question from the audiences. Okay, so Julie, I asked, would you please give a word for students and young researchers here who seeks their career development in a chronic pain research field? Yeah, please.
Yeah, I think it's a very worthwhile area to investigate. I was involved with giving a small talk to students who were doing an online master's degree, and part of their learning material was learning about under-researched conditions, and chronic pain was down there as an under-researched condition. So it's a very worthwhile, despite the frequency of chronic pain, it's very common in society, as we know from the Lancet papers back in the 1990s, and it comes up very high on the WHO burden of diseases. So it is a very worthwhile condition. And actually, when, for example, with the breast cancer literature, we know that from 1980s, they were saying it was a rare side effect. It is not a rare side effect. It can affect nearly half of women undergoing surgery in this example, but also we know for other surgeries as well, chronic postoperative pain is common. So it's a very worthwhile topic. So I wish you well in your careers investigating this.
Thank you very much, Julie. Yeah. Okay. Yeah. So the time is 7:01 p.m. in Korea. So today's talk and the Q&A time is finished. So thank you so much for giving us a fantastic talk and very informative and helpful the Q&A and discussions today. So thank you so much, Julie. And I'll hand over the mic to Professor Hyang-Suk Lee for closing.
감사합니다.
Okay. 감사합니다. Thank you. Thank you, Professor Bruce.
Thank you. Thank you all.